intraepithelial penile neoplasia. Then the TA is non-invasive localized squamous cell carcinoma. Then the T1, it is divided according to the involvement of the organ, that is whether it is the glands involved, the shaft is involved, or the foreskin is involved. For the T1 of the glands, it must the tumor invade the guard subepithelial connective tissue, that is the lamina propria. For the foreskin, the tumor invades the dermis, the lamina propria, and the dartos. For the shaft, any part of the shaft can be involved. The tumor may be present between the epidermis and connect up to the cavernosa. And the T1, it is divided into either the T1A or T1B. For the T1A, it is without the lymphovascular invasion or without the perineural invasion, or and it is not high grade. Then the T1B is when it is high grade, when it will involve the perineural invasion, the lymphovascular invasion. Then comes to the T2. The T2 is the tumor invades the corpus spongiosum with or without the involvement of the urethra. Then the T3 is when the tumor invades the corpus cavernosum with or without the urethra. This is different from the previous one. In the previous one, the T3 is the involvement of the urethra, and the T2 is when involve the corpora spongiosum and the corpora cavernosa. The T4 is when it involves the adjacent structures like the prostate, pubic bone, and the scrotum. Now comes to the lymph node status. Clinically, the N1 is when palpable mobile or the unilateral lymph node. N2 is palpable mobile or the bilateral lymph nodes. And the N3 when there is a pelvic lymphadenopathy or any inguinal lymph node that are fixed. Now, the pathologically these lymph nodes are if the N1 is when the less than two inguinal lymph nodes are involved. N2 is when more than three inguinal lymph nodes or the bilateral lymph nodes. And the N3 is when there is an extranodal extension or there is a pelvic lymphadenopathy. Now comes to the treatment of the primary tumor. The main aim of the treatment of the primary tumor is the complete removal of the cancerous part with the as much as the organ preservation as possible without compromising the oncological outcome. So the local recurrence has a little influence on the long-term survival. So the organ preservation strategies they are justified. Now comes to the management of the superficial non-invasive disease, that is penile interference neoplasia. The, the first line treatment for the carcinoma in the situ is the topical chemotherapy with the 5-fluorouracil or the imitumor. So the 5-fluorouracil, it should be applied daily for the twice daily for 2 to 6 weeks. And the imitumor it should be applied 3 times a week for the 4 to 6 weeks. The circumcision it is advisable prior to the use of the topical agents. Then the if this after the circumcision, the rebiopsy it is required to assess the response to these agents. If this topical treatment fails, it should not be repeated. The next option after the topical chemotherapy, it is a laser therapy. In the laser that are used for the CO2 laser and the NDA laser, the recurrence rate of the CO2 laser it is much more lesser than as compared to the NDA laser. That is approximate for the CO2 laser approximately from the 10 to 23% as compared for the NDA laser. It is up to the 48%. So the rebiopsy to see the response, it is mandatory to see the treatment control. The other options are the glance resurfacing, partial or the total glanectomy. It can be used in when the topical chemotherapy or the laser treatment failed, or it can be directly used as a primary. So the EAU recommends the topical treatment with the chemotherapy, then the laser therapy, and the glance resurfacing. So the management of the invasive disease that is confined to the glands, the small and the localized invasive lesions should receive the organ sparing the treatment. One other surgical options are the local excision, partial glanectomy, total glanectomy with the reconstruction. The other option for this are the radiotherapy and the laser therapy. And the disease that is confined to the glands with or without the urethral involvement. The treatment options include the total glanectomy with or without the resurfacing of the corporeal head. Then comes to the radiotherapy, and the other options are the partial amputation, which should be considered in the unfit patient. EAU recommends for the TA or the T1A given due to the wide local excision with the circumcision. Then the laser therapy, glans resurfacing, glansectomy with the reconstruction. Radiotherapy can be considered when the lesions are less than 4 centimeters. For the T2 lesions and the T1 G3 lesions, the recommended options are the wide local excision with the reconstruction, glansectomy with the circumcision reconstruction, radiotherapy for the less than 4 centimeter lesions. And the management of the disease that invades the corpora cavernosa with or without the urethra, the glansectomy with the distal corporectomy, and the reconstruction or the partial amputation with the reconstruction. The other options are the radiotherapy. Also, for the T3 lesion, the EAU recommends the partial amputation with the reconstruction or the radiotherapy for the lesions that are less than 4 centimeters. For the T3 lesion that involves the urethra, the total penectomy with the perineal hysterectomy, it is recommended, and the partial penectomy is also recommended. When it comes to the treatment for the locally advanced disease that invades the prostate, scrotum, or the pubic bone, the standard advisable treatment in this condition is the extended partial amputation or the total penectomy with the perineal hysterectomy. For the ulcerative lesions, the neoadjuvant chemotherapy followed by the surgery is recommended. Other options are adjuvant chemotherapy or the palliative radiotherapy. So EAU recommends the neoadjuvant chemotherapy followed by the surgery in the responder. It is weekly recommended. When it comes to the management of the local recurrence after the organ conserving surgery. After the recurrence, local recurrence, the long-term survival, it is not affected by the recurrence of the primary lesion. So the second organ conserving procedure can be considered in this patient when there is a corpora cavernosa is not involved. If these lesions are large or having the high grade recurrence, partial or the total amputation can be considered. So the EAU recommends that for the local recurrence, the salvage surgery with the penile sparing the small recurrences, or for the large with the high grade partial, the total amputation. These are these tables just the different treatment options having the local recurrence of the nodal. In the ND egg lesion, the local recurrence and the nodal recurrence have maximum. Now comes to the management of the regional lymph nodes. The development of the lymph node metastasis in the case of the carcinoma of the penis, it follows the same route of the anatomical drainage of the lymph nodes. That means the first involve the inguinal lymph nodes, followed by the pelvic lymph nodes. So the first lymph node that are involved in case of the carcinoma of the penis is the superficial medial, followed by the central group of lymph nodes. The lymph node metastasis from the pelvis to the retroperitoneal lymph node is considered to be a systemic disease. Then comes to the patient. Now the patient for the management of the inguinal lymph node status, the first most reliable tool for this is the physical examination. So that on examination, the three scenarios are possible. If on palpation, these lymph nodes are whether these are not enlarged or the palpably enlarged lymph nodes. The third condition is when the lymph nodes are grossly enlarged and these are ulcerated. So if the lymph nodes which are non-palpable, in these cases, this lymph node management depends upon the risk stratification that depends upon the grade, tumor, or presence or absence of the lymphovascular invasion according to the primary biopsy report. Then, according to this, these patients can be categorized into the low risk patients, intermediate risk patients, and the high risk patients. In the low risk patients, there are very lesser chances of the recurrences. So, in these patients, in the low risk patient, that is a carcinoma in the situ, localized non-invasive, and the T1 G1 cases, the patient can be offered the surveillance, and the EAU recommends in case of the non-palpable inguinal lymph nodes for the T1 G1, the management of this requires the surveillance. Then comes to the when the lymph nodes are not palpable and the grade is that the tumor is intermediate, having the intermediate risk or the high risk, then the none of the investigation can detect the micrometastasis when the lymph nodes are not palpable. So these are not recommended. Then the about the FNEC also does not diagnose the micrometastasis and it is also not recommended. So in the patients who have the primary pathology of the having the intermediate risk, that is the T1 G2, and the higher risk, that is the T1 G3 and all above T2 T3 T4. These patients in these patients the lymph node can be managed with the invasive nodal staging with the help of either with the dynamic sentinel node biopsy or with the modified inguinal lymphadenectomy. So the dynamic lymph node biopsy, sentinel node biopsy, it is done with a day before the surgery after injecting the 0.3 to 0.4 ml of the technetium technetium 99M nanocolloid around the lesion intradermally, and with the help of the gamma cameras, all the activity of this radioactive to be noted for the 15 to 20 minutes. After that, the static images from the anterior of the lateral should be taken for the next 5 minutes, and after 2 hours post injection. And after that, the lymph node that is getting the drainage, it should be marked with a marker. And at the time of the surgery, the patent blue dye should also injected that will this stains this lymph nodes positive and use and helps in the lymph node uh, identification of these lymph nodes. Then comes the modify the sensitivity, the outcome of the dynamic node biopsy. It is approximate sensitivity is about 90 to 94%. Then comes to the modified inguinal lymphadenectomy. In modified inguinal lymphadenectomy, the superficial, medial, and the central group of lymph nodes, it is removed bilaterally. Then comes to the in the patients who are having the patients in whom the if the lymph nodes with the dynamic sentinel biopsy or the modified inguinal lymphadenectomy it comes out to be positive, the ipsilater radical inguinal lymphadenectomy it is indicated in these patients. Now comes to the next scenario is the when the lymph nodes are the palpable. So the according to the EAU, the lymph nodes that are enlarged, it should be surgically removed, histologically assessed. If these lymph nodes comes out to be positive, then the radical inguinal lymphadenectomy should be performed in these patients. Ultrasound guided FNAC should be done in the doubtful cases. So the if the lymph nodes are palpable, then the CT or the MRI provide the staging information about the pelvic lymph node status. The PET CT is also an option. The sensitivity of the PET CT for the detection of the sensitivity and the specificity of the PET CT for the detection of the pelvic lymph node is 88% and the 98%. So the EAU recommends for the palpable inguinal lymph nodes, the radical inguinal lymphadenectomy in the first inguinal lymph node patients. Now comes to the pelvic lymphadenectomy. So the pelvic lymphadenectomy, it is indicated in patients who have the two or more inguinal lymph node metastasis on the one side or having the extra capsular lymph node extension or the lymph node that is more than 4 centimeters. This recommendation is based upon the one study that shows if the more than two inguinal lymph nodes are involved, there are the 23% chances of the pelvic lymph node involvement. And if the more than three inguinal lymph nodes are involved, there are the 56% of the chances of the pelvic lymph node involvement. There is also the one more criteria. If the lymph node that the cutoff value is three, if the three inguinal lymph nodes are involved, or the size of the lymph node, the cutoff value for that is 30 mm of the 3 centimeter, or if there is an extra nodal extension. If all these factors, that is, lymph nodes 3, or the size of the lymph node is a 3 centimeter, or the extra nodal extension, if all these factors are present, then there is a 56 to 57% of the chances of pelvic lymph node involvement. If all these factors are absent, there's almost a 0% chances of involvement of the pelvic lymph nodes. Then comes to the adjuvant the treatment. The adjuvant treatment, that is, it is recommended for the N2, N3 disease after the lymphadenectomy. Also, the recent study also confirmed the survival benefit of the adjuvant chemotherapy after the radical inguinal lymphadenectomy. The adjuvant radiotherapy after the inguinal lymphadenectomy, it should not be administered. So, according to the EAU recommends the adjuvant chemotherapy in the patients with the N2 and the N3 disease after radical lymphadenectomy, and the radiotherapy, it is not recommended for the nodal disease except just for the palliation. The management of the patients with the fixed inguinal lymph nodes. The patients who have the bulky, large, or the ulcerated inguinal lymph nodes require the staging with the CT, with the thoracic chest X-ray, abdominal pelvic CT, and for the systemic. Now comes to the management of this include the neoadjuvant chemotherapy followed by the radical lymphadenectomy in the responder. It is recommended. Now the management of the lymph node recurrences. So the regional lymph node recurrence, it should be treated in the same way as at the time of the management of the primary tumor. The patients with the regional lymph node recurrence after the dynamic sentinel node biopsy or the multiple inguinal lymphadenectomy, they are at the higher risk of the irregular metastatic progression. So there is no clear-cut evidence for the best management in such patients. The multimodal treatment with the neoadjuvant or the adjuvant chemotherapy after the radical lymph node surgery, it is recommended. This is according to the NCCN guidelines. The important is in the NCCN according to EAU, EAU recommends in the non-palpable patients, this imaging, it is not required because they does not detect the micrometastasis, whereas the NCCN recommends in the intermediate high risk cases the cross-sectional imaging of the chest, abdomen, and the pelvis. The EAU not categorize these patients of the inguinal lymph node according to the size of the fixation of this. The NCCN recommends that divides the patient the inguinal lymph node to the bulky or the pelvic lymph nodes enlargement. This is also the bulky means, and this the lymph nodes more than 4 centimeter, that is a mobile, or less than 4 centimeter lymph nodes that are fixed, or the bilateral lymph nodes, whether these are mobile or fixed, or the the next is the pelvic lymph node. And this is also this management of the metastatic according to the NCCN guidelines. In the metastatic patient, the systemic chemotherapy should be given. Then the cross-section imaging of the chest, abdomen, pelvis should be done. After that, the response of this patient can be seen in the complete response or the partial response of the stable patient. The consolidation surgery should be considered. So the consolidation surgery is the bilateral superficial and the deep inguinal lymph node dissection with the unilateral or the bilateral pelvic lymph node dissection. If there is a no response, then the patient should be considered for the subsequent line systemic therapy. In there is the panitumumab or the other is the doctor can be considered. There are then the role of the radiotherapy in the lymph nodes. There is a lack of the positive evidence. The lack of positive of the radiotherapy cannot be recommended for the treatment of the lymph node disease in the penile carcinoma. The prophylactic radiotherapy for the N0 disease, it is not indicated radiotherapy for the advanced lymph node disease, it remains a palliative option. There are some studies that shown the comparison of the adjuvant the radiotherapy and the chemotherapy. After they show the adjuvant chemotherapy, it is much more better than the much more superior than the radiotherapy. And the patients after the radiotherapy is compared with patients with the surgery. In patient the after surgery, the radiotherapy it is not given in the other patient group. Radiotherapy can be given. There is a no difference in the outcome. Then comes to the chemotherapy. These are the adjuvant chemotherapy in the node positive patient after the radical inguinal lymphadenectomy. The adjuvant chemotherapy in this patient is a that is a cisplatin 5-fluorouracil or the taxane group, paclitaxel, with the 3 to 4 cycles after the resection in the N2 and 3 disease. There is one study that shows the patients in whom the radical inguinal lymphadenectomy, the adjuvant chemotherapy is given, they have the more better survival as compared to the patient in whom the chemotherapy it is not given. Now, the neoadjuvant chemotherapy in patients with the fixed or the relapsed inguinal lymph nodes for the early treatment of the systemic disease and the downstaging of the inguinal lymph node metastasis. In the responder, the complete treatment is possible with a good clinical outcome. This is according to the NCCN guideline. The subsequent line systemic therapy for the metastatic recurrent disease. NCCN recommend the pembrolizumab in these patients for the unresectable or the metastatic tumors with a microsatellite instability, high tumors, mismatch repair deficient tumors that progress following the prior treatment. This is the combination chemotherapy regimen. In this, there's the taxane, the I-phosphate fibroracial, or the cisplatin. It is given in the paclitaxel. It is given 175 milligram per meter square IV over the 3 years on the day one. I-phosphamide on for the day 1 to 3, and for the cisplatin 25 milligram per meter square should be given on the day 1 to 3, and it should be repeated every 3 to 4 weeks. The other recommended chemotherapy is the 5-fluorouracil and the cisplatin. That is a continuous infusion of the 5-fluorouracil, 800 to 100 milligram per meter square per day IV. On the day 1 to 4, it can be given the 2 to 5th day, and the cisplatin should be given on the day 1 in the dose of the 70 to 80, and it should be repeated every 3 to 4 weeks. These are the guidelines for the chemotherapy according to the EAU. It should be the N2 and 3 tumor should be given the adjuvant chemotherapy after the radical lymphadenectomy. 3 or 4 cycles, it is strongly recommended. The in the patient with the non-resectable or the recurrent lymph node metastasis, neoadjuvant chemotherapy should be given followed by the radical, that it is weekly recommended. Like after the follow-up. So all the local or the regional nodal recurrences usually occur within the first 2 years of the primary treatment. After 5 years, all the recurrences these can be either the local or the new primary lesion. So the intensive follow-up is required for the first 2 years and the other for the next 3 years up to the 5 years. After that, motivated patients they can motivated patient for their self-examination. They should be the patient should be motivated after the 5 years. The patient who are not able to do the physical self-examination should be followed further. After the local treatment with the negative inguinal lymph nodes, the follow-up should include the physical examination of the penis and the groin region for the local and the regional recurrence. In the patients with the curative treatment for the inguinal node metastasis, the CT or the MRI imaging for the detection of the systemic disease should be performed at the 3-month interval for the first 2 years. This is the follow-up according to the EAU guidelines. In the patients who are managed with a penile preserving surgery for the first 1 to 2 years, these should be followed at the these should be followed 3 monthly, and after the 3 years up to 5 years, should be followed every 6 months with the regular physical or the self-examination. Repeat biopsy after the topical or the laser treatment for the penile intraepithelial neoplasia. It is recommended in the amputation period. It is followed up at the 3 months or at the 1 year. Of NCCN, according to NCCN, these patients should be followed up to the 10 years. From the 5 to 10, it should be followed every 12 monthly. And in these patients, and the patient is having who are in the amputation was done initially for the first 2 years, they are followed up every 6 monthly, but according to EAU, it should be followed every 3 months. Then the recommendation follow for the inguinal lymph nodes. So the surveillance patient should be followed for at the 3 months or at the 6 months with the physical examination. And in the patients and with the pathology, the lymph nodes are negative at the initial treatment. These should be followed for the first 1 to 2 years, the 3 monthly or at the 1 year with the physical examination. Ultrasound guided FNC is an optional. Then in the patients who are having the lymph node metastasis at the initial treatment, these should be followed at the 3 months or at the 6 months with the physical examination with the ultrasound guided FNC or the CT scan MRI may be the option. According to the NCCN follow this according to the lymph node. It is lymph nodes cannot be said. They should be followed in the year the 1 to 2 years every 3 monthly, or from the 3 years from every 6 monthly, and for the N0 N1 patients, it should be followed for the first 2 years every 6 monthly, and after that every 12 monthly, and to the N2 N3 patients should be followed for every 3 to 6 monthly, then during the third and the fifth year, every 6 to 12 monthly. Now the imaging, the chest X-ray should be done every 6 monthly, and the abdominal and the pelvic CT or the MRI. For the first year, it should be done every 3 monthly, and during the second year, every 6 monthly. Thank you.
Thank you, Harpeet. You can unshare your presentation. I welcome Dr. Ganesh Bakshi. Thank you, Dr. Ganesh Bakshi, for having joined us.
Good morning.
Good morning. Good morning. I can see that you are just probably in your clinic in the hospital
yes.
now. Yes.
Sorry, the morning time actually comes traveling, so I joined late.
But it's really an honor to have you with us in our teaching class. So this was, we started a kind of class on guidelines of various uro-oncological tumors. And so this was the first in our series of those guidelines. So I would request you to just give a brief comment on carcinoma penis guidelines, and what do you think that these, what are the highlights and what the our residents and the young consultants or the urologists remember?
So, sir, as you said, I'll make only brief comments. One thing is starting from maybe patient guidelines, like how the patient is approached. So one thing is mandatory whenever you see a penis possible patient in the OPD. Remember that your biopsy is mandatory. If you have any doubts on what is the pathology of biopsy, it is best to talk with the pathologist, or at times do a rebiopsy, because doing a partial or some kind of a penile procedure surgically without having a proper biopsy is actually not accepted in medicine. Secondly, coming to the controversies in management of penile cancer as regards to actual management and guidelines. I mean, I don't want to waste much time. Coming to evaluation, imaging is a big question. So local examination of the primary, our eyes and hands are pretty good, but we should always remember that there can be possibly skip lesions also sometimes. So try to palpate much beyond. If you have a doubt of anything, ask for high frequency sonography. If the penile cancer goes to the root of the penis, the whole mass is palpable. Like we feel sometimes that I should do a total penectomy. It is always worth doing a high frequency sonography or even a step further MRI imaging. That will tell us our proximal margins are going to be free or not, and how good is the urethra. I mean, the urethra, can we get it out nicely outside to get a perineal ureterostomy? So this kind of imaging for the primary is really important. I think it was there in the guidelines. Again, for the lymph nodes, many patients will be thin, many patients will be obese. So take your clinical call, how you are going to order your investigations. Today, guidelines, especially in penile cancer, tell us everything. Palpation, sonography, further imaging, and sometimes if the nodes are big, they even allow us a PET CT. Coming to management of nodes, it is usually very clear what we should do in clinically N0 and clinically N1. Problem starts with guidelines in clinically N2, that means multiple or bilateral, and clinically N3. Clinically N3, is the last category. So in Western countries, the patients present with not such presentations like what we see in India, especially. We see patients who are maybe late presenters. They are less compliant, probably sometimes. They are shy. They run away after the initial treatment. So our guidelines or our clinical follow-up protocol should probably be according to our patient. This is what always a lot of people in India feel. And we also feel the same thing, because coming to absolute guideline-based management in CN2, CN3, there are two things. One is neoadjuvant and other is adjuvant. So the Western countries are very much into neoadjuvant nowadays. And in most forums and in many new coming publications, neoadjuvant chemotherapy is kind of put forward. Although evidence for both is actually not so good. Level of evidence many times comes to level 3 only. But what is the problem with our setup is, if we are going to give chemotherapy in say CN3, CN3 will be, say, for example, a node which is just very big or ulcerated in the groin or big pelvic node. Sometimes we have to take a call between giving neoadjuvant chemotherapy in CN3 versus thinking that I can still operate the patient, because the lymph node mass or the conglomerate lymph node mass is above, or it is still above the vascular sheath. So it is partially restricted in mobility. Like it won't move totally, but it will have slight mobility. That means the vascular sheath is up. So we can at least remove that, and we can also tackle the pelvic lymph nodes. That is our call. Sometimes what happens is, if you give neoadjuvant chemotherapy in such patients, chemotherapy has a success rate of around 35%. These are Indian data published, 35 to 40%. So if you talk otherwise, I always feel that for say 55 to 60% will not have great benefit. Now, not have great benefit as two things. One is stable disease, and the other thing, stable disease is usually counted in the better ones. So this is a little progression versus gross progression. That means around 55 to 60% of the patients, if they have restricted mobility today, if I can operate, we are losing them. That is the thing. So this is what we have discussed with a lot of people in UK and US, but they tend to do neoadjuvant chemo more than us, and we tend to probably use adjuvant chemo more. Now, going by, for adjuvant chemotherapy also, there are two problems. One is European guidelines, which technically suggested that only chemotherapy is used, and the NCCN, which says that CTRT is allowed. So again, level of evidence is almost same. The problem is that we have our own data, which was actually presented by our radiation therapy department in one of the oncology conferences. A good data, properly kept and everything, but retrospective again. So that said that patients whom we had given adjuvant chemotherapy only for PN3. PN3 would be either inguinal lymph nodes with extranodal extension. When there is a conglomerate mass, there is extranodal extension between lymph nodes, or pelvic big nodes, again with pelvic nodes, or with even pelvic nodes with ENE. So those patients did bad actually. Most of them had a median survival, which we saw was around 14, 15 months, not more. And the ones in whom we had actually given CT plus RT, because we have a MDT here, all these patients go through that. And then we have given CT-RT to a good amount of patients. And nowadays, our radiation department has also had some special technique they have published. where the side effects of otherwise thought of about radiation are very kind of low with image-guided radiation therapy to the groins. This is what is coming up. So with this and with the CTRT given already to our retrospective patients, we found their survival is much, much more. In fact, some of them were still alive. This paper was presented just before COVID. So that time it was a very contrast that one group with adjuvant chemo was 14, 15 months and the other with CTRT was still alive. So these are the things. I think follow-up protocol, which was mentioned, probably NCCN was a slightly extensive follow-up, which again, we should follow in some patients. In some patients, we should go for the EAU kind of follow-up. USI also had some guidelines coming up. So for follow-up protocol, I think we should see that. Sir, I think these are my comments.
Thank you, Dr. Ganesh. Yes, so you brought out a few very important points. One was that we definitely has to have a biopsy before we proceed with a kind of partial or a total amputation, which clearly says that this is a malignancy, and there is no doubt about that. Secondly, you said about the new adjuvant and adjuvant chemotherapy kind of controversy between our country and the Western world. We tend to give adjuvant and they tend to give new adjuvant chemotherapy. And the third was about the radiotherapy. Probably radiotherapy may have some role in some of these patients of N3 or patients with positive pelvic lymph nodes. So you told us about the MRI, use of MRI to detect the lesion with the local extension also. The guidelines say that if you are doing an organ preserving surgery, then you actually do this MRI or Doppler ultrasound. What is your protocol? Do you actually even if you want to do a partial amputation or a glanectomy, you would like to do a MRI to know the extent of the lesion?
Sir, in routine cases, we actually, for a partial penectomy or glanectomy, we don't do MRI. If we feel that the lesion looks only in the glans, but there is some kind of query or induration kind of thing, then we would do a high frequency ultrasound to demarcate the lesion. But otherwise, in partial or preserving, we don't do, because we use frozen sections always, all the time. What I said was, sometimes what happens is there is a very big lesion and we don't know whether we'll be able to get it out with a total penectomy, because at times we have, even with MRI, we have been in the OT in a problem that now the successive margins are coming positive inside, and there is one or two patients we have ended up doing just SPC. So that was one thing. So that's why. But in small penile preserving, we actually, unless there is a suspicion, we don't do investigation. Okay. So we do local examination and visual.
All right. What about a dynamic sentinel lymph node biopsy? Do you do it?
Sir, we use both the techniques actually. We do dynamic sentinel lymph node biopsy with methylene blue ICG. Currently, our technician gun has some problem, but that is also there. So we have tried these three also. And I guess, that is a good technique. It does cost some time in the surgeries, but a good number of patients we also do with the modified inguinal lymph node dissection, which we remove groups 1, 4, and 5 properly with a small incision, less morbidity, and we send this for frozen. If we get a frozen positive, then we extend it to a complete ilioinguinal. Now, the only difference between what we follow and what is the guidelines, that also I'll tell you very honestly. So what we do is, because our frozen section, what they do, when they see a lymph node, they just take 2 sections. And probably this is the practice all over India. This is what we got. So the pathologists commonly say that when you send us a frozen material, lymph node especially, we take a lymph node, we dissect it out, and we take 2 sections, like one from this end or one from center or one from both ends. That's it. So what we do then is that even if we find one lymph node positive in the modified or DSLNB, we do a complete ilioinguinal lymph node dissection. The guideline says that up to 2 lymph nodes, you may not do an extended one, the complete one. But then we fear that, sometimes, the retrospective reports of these frozens into the actual pathology, they come like 2 lymph node positive, this positive. So even with 1 positive, we go ahead with a complete ilioinguinal lymph node dissection.
Okay, so you will do a pelvic lymph node dissection also in if one node.
Yeah, so that is the that is the deviation from guidelines which we do here, but then we adjusted it because of two, three things. One is because of the pathologists who say this way, then the patients are quite in India unreliable. I mean, sometimes they'll, even if they're educated, sometimes they don't come for some time. And then if lymph nodes are positive, it is if it is anything like N2, N3 in penile cancer, it is like sure shot, you are going to die sometime.
Exactly, exactly. So this is I think a very typical of carcinoma penis, that lymphadenectomy is plays a very important role, because once it is in the lymph nodes, it's almost a fatal disease. So definitely lymphadenectomy plays a very important role in prognosticating these patients. So you do frozen section biopsy in every patient, right?
So, sir, if available for the primary, we do.
Yeah.
If sometimes if like we have taken a partial penectomy at the end of the day and we are dead sure by everything that we have a good margin, 1 centimeter, then we won't do. Otherwise, in these DSLNBs and modified inguinal lymph node dissection, we do in every patient.
Okay. So, do you ever do lymphotropic MRI for getting these lymph node mets? No,
we don't have that facility, so we don't.
Yes, I don't know whether in India any center is doing it or not, but I think.
But sir, on a different note, I think even with only modified inguinal lymph node dissection, things are pretty okay. Like,
okay,
I have not seen a problem. Like once in 3 years or 2 years, we have got a report in modified that frozen is negative, and at the end, one lymph node is positive. So we have also got these situations, but once in 2-3 years, like. So, I mean, then we have observed and sometimes taken care as the patient progresses. Like.
Okay, thank you. Thank you very much, Dr. Ganesh. So I would now invite any other faculty who would like to have any comment or any query to Dr. Ganesh, or if you want to comment on the whole guidelines which was presented by Dr. Harpeet. Anybody?
Ganesh sir, good morning. Myself, Dr. Somenda. What is the role of PET-CT in the CA penis?
So see, I mean, the role was since past 2-3 years very clearly. It was the upcoming role, and we have big lymph nodes in the groin, or we have CN3 nodes with the pelvis involved. Then literature says that there is a role. You can do it as a one-stop investigation as a metastatic workup.
Sir, what is your practice, sir?
For the primary, I don't think there is a big role. Like,
okay, sir.
It's like for the regional and the systemic disease.
Okay. Yeah, I think the guidelines still are not very clear about the role of PET-CT. They would say either or. Probably either you do a CT abdomen and CT chest, or PET-CT straight away. So. All right. So any other query or comment from any of the faculty or even residents, please. Residents, come up if you have any question to Dr. Ganesh.
So I'll tell you one more thing actually, sir. There is this impact trial which is in US and Europe, and we do want to rope in India also in that, because we have a lot of penile cancer patients. But what has been happening, as we are discussing for the past 1 year within centers in India, is that all our practices are slightly different from different countries. So they also have an arm which is different totally. It is neoadjuvant chemo plus neoadjuvant radiation, and then operate on these lymph nodes. So that is also one arm in their trial, neoadjuvant chemo and radiation. But the basic difference is they don't see nodes which we kind of probably in India are seeing.
Right.
Okay, so there was on the chat.
Yes, the neoadjuvant chemo radiotherapy, does it not cause more of fibrosis and difficulty in doing surgery later?
So, sir, this has been our old experience. Everybody, including you, have seen patients in whom radiation given with the earlier machines and earlier templates was absolutely bad, and people with elephant legs and everything was seen. So now, I mean, at least in our center, they have actually published this template, which is a slightly newer one. It accommodates and actually covers all the lymph nodes which are supposed to be only coming from CA penis. Earlier, what used to happen is what they used to radiate the whole pelvis and they used to cause fibrosis completely. So here with image guided and IMRT, they target only these supposed to be penile cancer type of lymph nodes, and that is why the side effects are less. But even we have not been giving neoadjuvant radiation. I mean, we still fear that. So sometime we'll have to think about a trial arm which is there.
Right. So thank you, Dr. Ganesh, once again. So for the benefit of our residents, I would just try to sum up the whole thing of carcinoma.
No, sir, can I ask a,
Yes,
sir, can I ask a question?
Just waiting for your, yes.
But actually,
ahead,
we have just been unmuted right now. So we just wanted to ask him, according to him, which is the best incision that should be given? Because, over here regularly we are doing with maybe a single, oblique incision. So according to him, which is the best incision which causes less morbidity?
To tell you very honestly, there are many incisions in CA penis. What we have been commonly using here also is a lazy S plus the two incisions, two parallel ones, one below the inguinal ligament and one above. So what happens is nowadays we are slightly, when we have to do a complete ilioinguinal dissection on both sides. So what we are doing is we are taking two incisions which are horizontal below the inguinal ligament on each side. I mean, one on right, one on left. And the pelvic thing we are doing either by a single midline infraumbilical incision, like we approach a radical prostatectomy, extraperitoneal approach, and remove both because that saves the wound better. And sometimes I'm encouraging my residents to do a laparoscopic pelvic lymph node.
Okay.
So
thank you. Excellent, sir.
Thank
you, sir. Thank you.
And there was one question on the chat also regarding opposite side modified ilioinguinal. So it is not like opposite side. It is like if both sides are C and 0, then you do modified on both sides. So if one side we know it is positive already, then we would plan a complete ilioinguinal lymph node dissection on that side. The other side would go always for a modified. I hope I answered that question.
Right. So here in our center, we often do for prophylactic lymphadenectomy video endoscopic inguinal veil.
Absolutely.
What is your experience there? Do you do a veil there?
So, sir, we do very less often, honestly. And the reasons are very different. Like we have not yet done more and we kind of are short up with the time also here.
Yeah. Right. I think with time probably we will be able to know how does veil fare vis-a-vis open lymphadenectomy.
About this doing veil and ravel also, one question which we had discussed even in this West Zone conference, because I had moderated this CA penis session. So what happens is when we are doing for a CN0, when we are doing a lymph node dissection, which is say modified lymph node, modified inguinal, we remove only those groups like superficial to the fascia lata, 1, 4, and 5 is actually around the fossa valis. But when we take for a veil or a ravel, we do something which is like a complete inguinal dissection. We take the fascia lata total up. So there is a small difference in the templates which we achieve. I mean, I have discussed.
So we can do both ways, right?
And yes, we said the same thing that in veil or ravel, what we do is we remove the whole inguinal tissue. And in simplified, we just remove the tissue in a particular lymph node set above the fascia lata. Obviously, in veil ravel also you preserve the saphenous vein, but the tissue removed for a CN0 patient is also quite a big tissue.
Right. Thank you, Dr. Ganesh. Once again, and anybody has any other thing? Otherwise, I will just wrap up with a summary for the benefit of the residents only. Yes. So, thank you, Dr. Ganesh. It was a wonderful interaction. And for the residents, carcinoma of penis, you see, it may not be a very common in Western part of the world, but definitely it is very common in our part. So you must be very thorough with the management of carcinoma of penis. And invasive penile carcinoma is a fatal disease. And the preventive measures for carcinoma of penis could be besides the hygiene and the neonatal circumcision and all that, HPV vaccination. HPV vaccination is coming up quite in Western world. They are giving HPV vaccination, and probably we also might be giving it in many of these patients. So early diagnosis and treatment is very vital for prognosis of disease in carcinoma penis, and staging and grading again is very important. Many of these patients who have non-palpable lymph nodes may have 10 to 40% incidence of micromets in these nodes. That is why prophylactic lymphadenectomy is so important in these patients. Of the type, 95% is squamous cell carcinoma, and rest may be basal cell, melanoma, etc. There are various risk factors like STD, smoking, balanitis, uncircumcised penis, etc. The pre-malignant conditions could be cutaneous horn, lichen sclerosis, keratotic melanitis, and the penile intraepithelial neoplasia includes erythroplasia, Bowen's disease, and Bowenoid papulosis. And for the lymph node management, if it is a non-palpable lymph node, the low-risk disease, do surveillance. If it is a high-risk disease, then you have to either do a MRI pelvis or a CT scan pelvis or even an ultrasound, and go ahead with inguinal lymph node dissection or a dynamic sentinel lymph node biopsy or a video endoscopic inguinal lymph node. In high-risk disease, you have to go ahead with this, and low-risk disease surveillance. If it is palpable disease and a low-risk disease, you can do a percutaneous excisional biopsy or a FNAC. And if it is a high-risk disease, then definitely inguinal lymph node dissection. And if it is N3, then pelvic lymph node dissection. And if that is positive, then again go ahead with adjuvant radiotherapy or chemotherapy. If it is bulky lymph nodes, do a percutaneous biopsy. If it is positive, then there is a role of neoadjuvant chemotherapy. If there is a response to chemotherapy, go ahead with inguinal lymph node dissection. If there are pelvic lymph nodes, and if they're positive, then do a percutaneous biopsy. If positive and resectable, give neoadjuvant chemotherapy. If non-resectable, go ahead with chemoradiation. If the patient is presenting with metastasis, chemotherapy has to be given. If there is a response, then you can go ahead with consolidation surgery. If there is no response, then we have to give second-line chemotherapy and supportive care to these patients. So risk stratification is very important in these patients. We know low risk includes TIS, TA, T1A, and no lymph nodes. And high risk will include T1B, T2, and any lymph node positive. So thank you once again. With this summary, we wrap up the session. Thank you, Dr. Ganesh. Thank you, all the viewers. Thank all the faculty members and residents of SMS Urology Department and all others who might have joined us today on either Zoom or YouTube. Thank you again. A very good day ahead. Thank you very much. I would request our moderator, please, Somenda, give a vote of thanks to. I'm really sorry for that.
Yeah. Thank you, Sevan sir and Ganesh sir, for excellent discussion and sharing their knowledge. And thanks to all faculty member and resident for attending this academic session. And thanks, Harpreet, for nice presentation. Thank you, sir.